Hello, partnering for vaccine equity, learning community members, and others working on vaccine equity, and welcome to this afternoon's learning event. My name is Kristen Brown, and on behalf of our team at Urban Institute, thank you for joining us. Today's event is the fourth installment of our Social Determinants of Health series, which will occur on the third Wednesday of every month. Today, we will hear about the importance of sleep to overall health and well-being. Our featured speaker will discuss how sleep varies by demographic characteristics and how this variation contributes to health disparities. Before we go further, I'll do our typical quick review of how this session will work. You've all been muted upon entry to the session. There are a lot of us, so staying on mute unless you are speaking is key to keeping the discussion going without accidental interruptions. You do have the opportunity to speak your question rather than type it into Q&A. It's your choice. If you want to speak your question, use the raise hand feature and we'll unmute you. If you want to type your question, use the Q&A tab to do this, and you can ask a question at any point during the session. The chat room feature is also open today, and we encourage you to chat amongst yourselves as you like, but please use good chat room etiquette. By this, I mean do not post questions for the speakers in the chat because we might not see them there. And though this probably goes without saying, please be civil to one another and to our speaker while chatting. We have begun offering live interpretation from English to Spanish during our events. If you would like to listen to the Spanish language channel, simply click on the globe icon in the Zoom taskbar at the bottom of your screen. Finally, as with all learning events, we will post the slides and a recording of this event on our community website and circulate them through the digest that go out through the CDC-managed Adult Vax Program listserv, which all members should be a part of. If you have technical difficulties at any point during the session, send an email to our community manager's inbox at vaxequitylearning@urban.org. We'll be watching the inbox and we'll try to help you as quickly as we can. And now it is my pleasure to introduce our featured speaker. Dr. Dana Johnson is a sleep epidemiologist and assistant professor in the Department of Epidemiology at the Rollins School of Public Health and Emory University in Atlanta, Georgia. Her research is aimed at understanding the social and environmental determinants of sleep disorders and insufficient sleep and the influence of sleep disorders and disturbances on various health outcomes. Dr. Johnson also conducts intervention studies exploring how stress reduction or home improvements can improve sleep and reduce subsequent risk for poor health outcomes. She is engaged in community partnerships to investigate the effect of environmental exposures and housing on health amongst residents of Georgia. Before joining Emory University, she received her doctorate degree in epidemiologic science from the University of Michigan and completed a postdoctoral fellowship in sleep and circadian disorders at Harvard Medical School and Brigham and Women's Hospital. Thank you, Dr. Johnson, for taking the time to speak with us this afternoon, and I will hand it over to you now.
Thank you, Dr. Brown and colleagues, for inviting me to talk today about one of my favorite topics. So the title of my talk is Sleep Health Disparities, the Role of Social Factors in COVID-19. So there are about four specific lecture points that I'll make today. And the first is that sleep is essential to health and well-being. So I'll take you through the importance of sleep and the consequences of poor sleep and sleep disorders. Second point is that there are racial, ethnic, and socioeconomic disparities in sleep. I'll show you some examples from the work that I've done, which really illustrate the disparities that we see in sleep. The next point is that sleep disparities are shaped by social factors. So I'll discuss the multi-level factors that are likely contributing to sleep health disparities and overall disparities. Some of this was discussed in a prior lecture that you attended. The point today is that I'll connect that to some of the health outcomes that we're exploring, particularly sleep. And then lastly, I'll show some empirical evidence illustrating that social factors, sleep, and COVID-19 are connected. So to begin, sleep is essential to our health and well-being. It's absolutely vital to our survival. I really like this definition that was included in a paper in Science not too long ago, and it reads, sleep is a non-negotiable biological state required for the maintenance of human life. Our need for sleep parallels those for air, food, and water. And so typically we think a lot about how diet is connected to health, as well as physical activity. These are really consists of the three pillars in addition to sleep of health. But unfortunately, sleep does not get the same recognition, but it is as important as diet and physical activity to helping live a productive and well life. So sleep is an important determinant of health. So when we sleep, there are important activities that occur that correspond to our ability to function in everyday life. For example, when we sleep, this is a time that our memories get consolidated and we go through that learning process. Also, it's important for our emotional regulation. I'm sure many of you can think about a time that you were exhausted and you may have been a little bit more irritable than normal. It's also important for our immune and inflammatory function. And I'll talk a little bit about this in relation to COVID-19, how sleep is important and gives us a boost to our immune system and really helps us be able to fight off infectious diseases. And then also sleep is important for our metabolism. There are important hormones that are secreted during our sleep cycle that makes our us have the ability to be able to know when we feel full and also when we are hungry. And then the other piece is when we have a shorter sleep duration, we're awake longer, which gives us more opportunity to consume more calories, which are related to obesity and other cardiovascular outcomes. And so for cardiovascular regulation, also when we sleep, our blood pressure dips, which is important. We give a rest, and we also have healing and repairing to our blood vessels. And then sleep is important for our performance, our ability to perform at work in our everyday lives with the vigor that we really intend. We need restful sleep. And so here's a figure just showing how sleep is important to these different areas, some of which I've mentioned, but I want to highlight a few others, such as our ability to make decisions, also our focus and concentration. The other piece is when we're sleep deprived, we tend to be more sleepy, and drowsy driving is as detrimental as drunk driving. And so we see an increase in accidents, both occupational as well as driving, when people are sleep deprived. And it's also critical for our mental health. And so the other piece about sleep is to know that it's a multi-dimensional framework when we think about sleep health. And this really corresponds to activities that are adapted to the individual social and environmental demands that promote our physical and mental well-being. And so when we talk about sleep health as this multidimensional framework, it consists of more than just how long we're sleeping, but also our sleep regularity, how consistent our sleep schedule is across an entire week, our satisfaction with our sleep, our alertness during wakefulness, our sleep timing. So, at what point in the day are we actually sleeping? And then our sleep efficiency, which really is defined by how much of the night that we're actually sleep, if we're sleeping at night. So, really, our sleep period. And then sleep duration, which gets really most of the attention that we can think about. And this is just how much of the time during the sleep period are we actually sleep. So, the amount of hours. And so, depending on how you score across these various dimensions, being on the optimal side is related to better health outcomes. And the way that we remember these different dimensions is through this acronym, Are You Sated? And so sleep is regulated by two body systems. One is process S and the other is process C. But the important piece to remember here is that when we are awake, so from the time we wake, constantly throughout the day, we're building our sleep load, and that's our process as shown here. So throughout the day, we're building this drive, our sleep load, and it'll continually increase, and then it'll get to a point to where it hits this maximum and we just can't stay awake any longer. And then we sleep and it depletes that sleep load. And then our process C, which is referred to as our circadian biological clock. We all have these internal clocks that control different functions, including our sleep-wake cycle. And so process C is this internal circadian rhythm, but it controls our timing of sleep. So our wake propensity throughout the day, and follows that same pattern as shown with process S. And so the important piece here is that the circadian rhythm is controlled by the light-dark cycle. So light is really important to our sleep-wake function. It controls our drive. It helps us feel alert. And so the timing of our light receptors are really important. So getting light during the day and having decreased light exposure during night translates to the optimum sleep-wake cycle. And so sleep changes across the life course, but the important piece here is to recognize how across our lifespan, our need for sleep changes. So starting with newborns who need the most amount of sleep, so up to 18 hours, across to older adults who require about, on average, 7 to 9 hours to have a healthy life. And so, unfortunately, although we have this important need for sleep, we see that sleep disorders and poor sleep are actually highly prevalent, and sleep disorders tend to be undiagnosed. So, I'll go over just a few sleep disorders. So, insomnia, which is a condition in which there's a problem either initiating or staying asleep, affects about 10 to 25% of the population. And I'll show you throughout the presentation how insomnia increased for many individuals during the height of the pandemic. The other common sleep disorder is sleep apnea. This is a condition in which there's an obstruction in their airway, and this causes brief pauses in breathing around 10 seconds every hour during the sleep cycle. And so this can translate to more than 30 times for someone that has severe sleep apnea to stop breathing. And that's highly related to things like cognitive decline. And then there's periodic limb movements or restless leg syndrome, which affect about 10% of the population. And these are conditions in which there's an urge to move your legs, and that can interrupt sleep. And then circadian rhythm disorders. The way to really think about this in terms of making it more digestible, to think about flying across time zones. And so when someone has a disrupted circadian rhythm, they can feel jet lagged. And then short sleep duration affects about 40% of our population, and sleep difficulties affect about 25%. And the way that these operate to affect overall health, quality of health, and other outcomes, including mortality, is through altering our metabolism, inflammation, oxidative stress, and our autonomic function. So here's a figure that shows a circadian healthy clock on the left, which again, as I mentioned, controls our sleep-wake cycle, but also controls other things like our blood pressure, which has a 24-hour cycle. And so this can be altered by different behaviors as well as occupations, such as shift work. I talked about jet lag. And so really with shift work, we're talking about individuals who are working at a time that their bodies are telling them to be asleep. And then other things like aging can alter this, and that can translate into things like a poor sleep quality, impaired muscle function, cardiovascular disease, hypertension, and others. And then some of those other consequences include things like impairment, sleep deprivation, being related to immune function. So here's a nice figure that was created by one of my colleagues at the University of California, San Francisco, which really highlights the importance of sleep duration in terms of being protective against the common cold. And so here you can see for an individual adult who sleeps at least 7 hours or more, they have about 17% chance of catching a cold when exposed to a virus. Now, you can compare that to someone who sleeps less than 5 hours, which is a short sleep duration. This person has a higher risk, so 45% higher chance of catching a cold when exposed to a virus. So this is really illustrating how sleep duration, the higher amount, so a longer sleep duration is really protective against things like the common cold. And so, unfortunately, sleep is not equitable. And so, there are disparities. And so, when we talk about disparities, we're really talking about differences that are unnecessary, avoidable, unjust, and unfair. So, these are the key terms to think about when we're talking about a disparity. And so, here's a figure just showing the prevalence of different conditions: diabetes, hypertension, heart disease, stroke, deaths, and HIV infection across these different racial ethnic groups: white, Asian, Black, and Hispanic. And so, for the sake of presentation, I'll just point to Black individuals where you can see the difference in their prevalence. So, how likely they are, or how common a condition is in these groups. So you can see for hypertension, it's about 40% compared to less than 30% for white individuals. And so the reason for this difference really relates to things like social factors, which are unfair and avoidable. And so that's what makes this a disparity. And so, in terms of a sleep health disparity, this is a definition that we use, which reads a difference in one or more dimensions of sleep health. So, those are the dimensions that I mentioned earlier that occur on a consistent basis that adversely affects designated disadvantaged populations. So, this is really beyond racial ethnic groups, but I'll talk about those, but also individuals of lower socioeconomic status, individuals that identify as sexual minorities, as well as others that have been historically minoritized. And so, in some of the work that I will show, and just generally in the field, you often see the term race being used, but really it's not race that we're thinking about as this risk factor. Race is actually a social construct that is a rough proxy for sometimes socioeconomic status and other times culture, or really how a person is navigating life and how they are perceived by others. And so race is precisely measuring that social classification of people in our race conscious society. And so, really, we're hypothesizing that racism is the fundamental cause of sleep health disparities and not race. And so I want to show you some data, again, highlighting racial ethnic disparities in sleep. And this is really showing how historically minoritized individuals have a higher burden of sleep deficiencies and more sleep disorders. We also see that poor sleep and sleep disorders occur earlier in life for racial ethnic minorities than for non-Hispanic white individuals. And when it does occur, it's also more severe. So here's a table just highlighting some of the sleep characteristics by race ethnicity in comparison to non-Hispanic white individuals. This is from a table that I published a few years ago, where we found that Asian, Black, Hispanic, Latino, and Native Hawaiian and Pacific Islanders have shorter sleep duration in comparison to non-Hispanic white individuals. And although American Indian and Alaska Natives are included in studies less often, we have seen in these few amount of studies that their sleep tends to be longer. And so I talked a lot about short sleep duration, but also long sleep duration can also be poor for health. particularly those that sleep longer than 9 hours, tend to have worse health outcomes and also tend to have depression. And then for sleep quality, we saw that this was worse for Asian and Black individuals, but it was mixed for Hispanic and Latino individuals. Which, in digging a little deeper, we found that this was really the result of whether or not the social classification was measured. So understanding experiences of acculturative stress, also of discrimination, which really can be measured using scales, but also country of origin and skin tone. So what we're seeing is that individuals from Latino backgrounds tend to have those with darker skin, their sleep tends to mimic those of Black individuals. And those with lighter skin, their sleep tends to mimic those of white individuals. Again, really pointing to that social construct and also experiences in society. And so across these groups, we see worse or more severe sleep apnea and also a higher prevalence of insomnia, although the data are mixed for Black individuals, which point to things like social stigma around sleep, where Black individuals are less likely to complain about sleep. But when we measure their sleep objectively, we see that it takes longer for them to fall asleep. And also they have more interruptions during the sleep cycle. And so in terms of insomnia, as I mentioned, when it occurs, it's more severe. So we see that Black individuals in particular have about a 67% increased risk of insomnia and short sleep duration. And also that racial minorities are 2 times more likely to exhibit chronic insomnia in comparison to non-Hispanic white individuals. So in addition to race ethnicity, we see differences by income. Here's a figure comparing individuals who sleep less than 6 hours and those that sleep greater than 7 hours. And so we see those who have less than a $30,000 annual household income. It's a higher percentage of those who are sleeping less than 6 hours in comparison to those that have more than $75,000 annually. A lower percentage are sleeping less than 6 hours, and a higher percentage are sleeping less than 7 hours. So we see a clear trend here as household income increases, the proportion of those sleeping more than 7 hours increase. And so there's an intersectionality that we're also seeing here. So how both race, ethnicity, and occupation intersect in relation to short sleep duration. So typically what we see is, as I showed you in the last slide, when education or income increases, we have better health outcomes. But I want to challenge that, showing some data here that gradient is not the same across race ethnicity. So here on the left, this is a figure showing the prevalence of short sleep duration by different occupation categories: professionals, support, and laborers. And so on the left are men and on the right, women. And so here we see that in this higher socioeconomic category, professionals for Black individuals, they have the highest prevalence of short sleep duration, while those that are laborers have the lowest prevalence of short sleep duration. And we see the opposite. So that's the dark green bar for Black individuals. And then this lighter green bar represents white individuals, where we see that the prevalence of short sleep duration is lowest for professionals, which is what we would expect, and highest for laborers. So the point here is that we are seeing worse sleep among Black individuals at higher socioeconomic status, at a higher SES. And then if we look at for women, we really see no differences here for laborers, but this greatest disparity, again, is shown among this higher SES group. And so you may say that's one study. So here's another one showing education, so a different metric of socioeconomic status. And we see the same thing. Here's white individuals, Black and Hispanic. So for Black individuals, as education increases, we see a higher predicted probability of short sleep duration for Black individuals, and then it's lowest for white individuals. So what's causing this? What's pointing towards why we're seeing this different gradient? So there are specific factors that those of higher SES Black individuals may be more exposed to, things like discrimination and racism, since they're more likely to be in environments to where they are the minority. So social determinants, these are a broad range of non-medical factors, so social, economic, psychosocial, behavioral, that can either directly or indirectly shape health outcomes, and in this case, sleep health. So in the past lecture, you talked about upstream and downstream factors. So this is just illustrating upstream are the economic and social opportunities and resources that are shaping our individual personal behaviors, our access to medical care, and so those more downstream. And so it's those upstream factors that are pointing to the fundamental cause for health disparities. So if we think about the upstream, the inequality and opportunities and discrimination, which shape individual experiences and behaviors and lead to downstream health outcomes. And so how does that work? So structural racism or discrimination as our root cause contributes to different laws, political processes, budgetary decisions, which determine resources for public health and healthcare, education, our neighborhood environment, economic stability, which relate to health and well-being. And I want to take you through an example that was created by the American Heart Association, which really illustrate how historical experiences such as slavery can affect downstream health outcomes. And so here's slavery at the top, which produced structures of racism to maintain white supremacy. And this can be seen through post-emancipation structures of racism to maintain white privilege. That was illustrated through things like the Jim Crow laws, segregation. Redlining is an example that targeted Black individuals. So redlining being these neighborhoods that were outlined in red by banks were deemed undesirable, and investment was withheld from those communities. And we see present day still lasting effects of redlining, where this has contributed to wealth gaps. So individuals were denied mortgages or were given very high interest rates. And so that also led to concentrated poverty and those social determinants of health that I mentioned through this racial bias in the justice system. And so this contributes to things like poor access to healthcare, poor housing conditions and physical environment, poorly funded schools, and poor access to capital. And so in thinking about this poor access to healthcare, we know that that affects things like our vaccination rates, having that access to care. And then also access to care directly is associated with increased risk of heart disease and stroke. And then these other factors also relate to toxic stress, which leads to an increased burden of heart disease and stroke, and also worse cardiovascular and stroke outcomes. So this is showing how slavery, which began in 1619, has these long-lasting effects and how it operates through these upstream laws, which really dictate the systems in which we operate that determine our access to care and our vaccination rates and our downstream health outcomes. And so determinants of sleep health disparities are multifactorial and occur across the lifespan. So there are social determinants, which I mentioned, and then there's also environmental factors that shape our sleep health. So our housing, our exposure to light or inopportune exposure to light. So lower income areas tend to have brighter lights, which were intentionally designed to deter crime. But depending on someone's housing structure, that can translate into inopportune light exposure for the individual, which can disrupt their sleep. And then there's sleep health related behaviors, which are a consequence of policies. For example, minimum wage is not a livable wage. So someone who has a family that's making a minimum wage may need multiple jobs, and that can prohibit them from having a consistent bedtime for themselves and also for their children. So while that's an individual behavior in terms of consistent bedtimes, it's a reflection of societal laws that really prohibit them from having a consistent bedtime, for example. So these can individually and cumulatively relate to disparities in sleep health and disorders. And so the other important piece here is to think about how, as the individual, we're nested within a broader context. So our OSA is obstructive sleep apnea. And so our exposure to sleep disorders or sleep patterns, how that bidirectionally relates to our health, are dependent on things like our race, ethnicity, also the family in which we're nested, beliefs about sleep health, our resources within our households, which are really a consequence of our broader environment, things like systemic racism, our insurance coverage, and then also access to care. So I want to transition and talk about sleep disparities in COVID-19. So we saw that racial minorities and lower income individuals were more likely to be essential workers without protections. So these were individuals who did not have paid sick leave in order to take off during the pandemic. These were also individuals that were on the front lines, that had to work and did not have the privilege to work from home. And that translated to an increase in public exposure. So thinking about individuals that were working at grocery stores or delivering groceries to individuals who had the privilege to stay home. And then also they were more likely to reside in substandard multifamily units, which translates to crowding and a higher risk of transmitting different diseases. And once one person may have had COVID-19, it could spread more easily through that family and the household. Then we also saw an increase in anxiety. And at the same time of the height of our pandemic, we also had a lot of civil unrest. We were witnessing police brutality through murders such as George Floyd. And so this translated to an increase of experiences of vicarious discrimination or racism, which really means witnessing the act of someone else encountering racism. And then there was also increases among this population in mental health, so depression and also grief, more losses. So here's a figure just showing how social vulnerability, which is measured through socioeconomic status, household composition, minority status, and housing type and transportation accessibility, how that was associated with the increase and case fatality rates due to COVID-19. And then additionally, SES, so being of lower SES and being a racial minority, was associated with an increase in COVID-19 incidents. And so during the pandemic, in terms of sleep, we saw an increase in insomnia symptoms for all individuals. And then I'll show you some data showing how it was a higher increase among racial ethnic minorities. And then a good thing that happened for teenagers was that they slept more, which underscore the importance of things like school start time policies in order to give students, young people, a more opportunity to sleep. Now, here's some data from a study that we conducted that was led by one of my collaborators, where we found that these different factors, such as COVID threat, losing a job, getting a pay cut, and difficulty with childcare, were all associated with the increase in having problems or troubles with sleeping at night. And then in terms of sleep COVID-19 disparities, here's another study that we conducted using a community sample of Black and white individuals, where we saw that Black individuals had a higher insomnia severity index, so a higher score on insomnia severity scale in comparison to white individuals. Black individuals had a higher insomnia score. And then we also looked at coronavirus impact scale. So how much an individual were impacted by the pandemic. And we saw that Black individuals were more, had a higher score. So meaning they had more of a negative impact on their lives in comparison to white individuals. And then also how much of that impact affected them in terms of stress. It was also higher for Black individuals in comparison to whites. And so in the same study, we found that in comparison to white individuals, Black participants were 2 times more likely to be unable to pay for essential needs, 2.3 times more likely to have a COVID-19 diagnosis in their immediate family. And then they were also more likely to have 4 times more likely to have a COVID-19 diagnosis in extended family or close friends. Again, think about those prior slides when I talked about these individuals are more likely to be essential workers and not have worker protections. And so we also saw that COVID-19 symptoms were also more severe due to things like underlying symptoms of chronic diseases such as hypertension. And so we looked at how much of the impact of COVID-19 was explaining the racial disparity in insomnia. And we found a really high percentage, 70% of the racial difference in insomnia was due to the impact of COVID-19. So in other words, if someone was not, a Black individual was not affected by or impacted by COVID-19, we could potentially eliminate 70% of the difference in insomnia severity between Black and white individuals. And then in terms of that COVID-19 stress response, it explains 66% of the difference in discrimination being related to insomnia. So we measured discrimination before the pandemic and had measures after. So we saw those with who experienced discrimination before COVID, they were more likely to have a stress response to COVID and more likely, which resulted in a higher insomnia severity score. And so again, COVID-19 explaining, or stress response, explaining 66% of that association. So what can we do about all of this? So taken together, this all points to sleep as this point of intervention to reduce susceptibility. But to do that, we also have to address those social determinants to prevent having poor sleep and also prevent those subsequent health outcomes. So what can we do? So one thing is preventing the sleep debt from occurring. So we can think about the sleep debt similar to financial debt. It takes time to repay. So there's a study that has shown it takes 4 days to recover from 1 hour of sleep loss. And so there are other studies that have shown it can take up to 9 days to totally eliminate the sleep debt that someone accumulates when they have a shorter sleep duration. And then another way that we can temporarily help with this is to have healthy or take healthy naps. And so by healthy, that means napping at an appropriate time and not napping longer than 20 minutes. And then also just returning to our normal sleep patterns. Here's a figure that we put together from a study that I was part of, which really shows across the day, from wake up to bedtime, the activities that we should engage in. So we want to make sure that we're waking at the same time every day, that we're getting light exposure earlier in the day, taking naps and having caffeine earlier in the day. Now, by the evening, we should stop electronic use, have no naps, stop caffeine or consuming sugary beverages, and also no alcohol within 2 hours of bedtime. And then make sure we create an environment in which is conducive to our sleep. So, being in a dark, quiet, cool bedroom. Now, it's important to understand that, again, there's some privilege in being able to have a bedroom that's conducive. So, for example, some of the work that I've done has shown that individuals who live in unsafe environments sleep with the television or light on as a safety measure. And so they are trying to prevent someone from breaking into their homes. So they're using noise and light to let people know someone is here. So the challenge is on us sleep professionals to really come up with ways in which we can increase safety, which can be a policy change in order to allow people to live in environments that are conducive to a healthy sleep pattern. And so other things, if someone is exhibiting symptoms of a sleep disorder, it's important to talk to the doctor about it, and also to get screened for sleep studies or have a sleep study to get screened for sleep disorders. And then once a diagnosis comes, to be sure to get the appropriate treatment for that sleep disorder. So things like over-the-counter melatonin is not an effective treatment. And so you'll want to talk to your physician about appropriate treatments for sleep disorders. And so I want to end by just showing this figure that really illustrates upstream and downstream factors, which point to current public health practice on the right as downstream, but also showing the upstream factors upstream as emerging public health practice, where our efforts should really be targeted in order to prevent those downstream. So those are things like addressing social inequities, and that can be done through revising and really focusing in on institutional inequities. So through government agencies, schools, laws, and regulations. So through efforts such as those implemented by the Urban Institute, with just bringing recognition around these social determinants and how that is dictating our living conditions, which control our access to care and shape our risk behaviors. They forgot sleep, so I added it for them. And then also that would shape things like our vaccination rates and having strategic partnerships with the community to advocate for appropriate access to care, which can translate to improvements in vaccination rates. So lastly, I will end with summarizing those points that I made. So going back to those lecture points. So hopefully I have convinced you that sleep is essential to your health and well-being. We see that historically minoritized individuals have worse sleep. And the reason for that points to social factors, things like stress and environmental factors are contributing to these sleep disparities. And then also we see that COVID-19 is socially patterned and is associated with worse sleep. And then lastly, targeting sleep can potentially help to improve our overall health. And so I will end with just acknowledging some of the collaborators from who led some of those studies that I showed from the work that we've done in my research group, the Sleep Epidemiology Research Group, And then also my funder, the NIH, who's funded the work that I presented today. And we have a good 15 minutes for questions. I'm happy to answer any. And if we run out of time, or if you need to contact me, here is my email address, and I'm also on Twitter. So thank you for your time.
Dr. Johnson, thank you so much for an awesome presentation. You're right, we think so much about things like physical activity and diet are the immediate things that we think about changing our health behaviors, but sleep is definitely an understudied aspect. We do have a question in the chat, and if others have questions, put it in the Q&A. The first question is it electronics that affects sleep, or is it the light from the electronics? Does like nightshade, for example, on a Kindle, eliminate the problems with electronics?
Excellent question. So there are different ways in which these electronics disrupt our sleep. And so one, you're absolutely correct. It's the light exposure that can delay sleep onset and also the maintenance of sleep. But additionally, using these electronics also translate to more engagement. So you're looking at things and being more engaged. So there's data that shows that someone who uses electronic before bed, they're more likely to stay engaged on that, whether it's social media, which will also delay their sleep onset. And then the other piece, so this engagement and the content, then it's also about what the person is viewing online. So depending on what's being viewed, it could also increase things like anxiety and stress, depending on if they're viewing content that can be triggering. So it's both light content and then the actual engagement that are leading. And so in terms of just the light exposure, let's say someone is reading something that is not triggering, there are night settings and dim light that can be used, which is totally fine as long as that is not, the content is not something that is delaying sleep onset.
Thanks. I have another question. So I don't know, has there been any literature out about working from home? So I think about like working from home and how that disrupts the pattern of my day. If I go in some days, don't go in other days. And how has that affected, I guess, sleep overall for people?
Yeah, really, really great question. So we don't have as much data around working from home and sleep patterns. What we do have is data from younger individuals about being home for school and sleep patterns. So we actually saw that sleep in some ways improved for students because it reduced their transit time. School start times are very controversial. One, because, well, one, we should have, per the CDC's Healthy People 2030, the goal is to have no school start times earlier than 8:30 a.m. And so what we see for some students that they school start times at like 7, so they're getting up at like 5 a.m. So that transit time was eliminated, which allowed them to sleep longer. And so I would argue that we can translate those findings to work from home being the same. And for some places like DC or New York or Atlanta, where there's a lot of traffic and commute times are longer, it definitely can relate to translate into a longer sleep duration and better sleep patterns. But on the other side, working from home, depending on structure, can also be chaotic, right? So lots of people with families talked about having to be the teacher at home for their kids and work their jobs. And then additionally, for those that, let's say you're alone, there's data potentially from some of the work that our Surgeon General for the United States is conducting, looking at loneliness as a risk factor of poor health outcomes. So there's different pathways by which being home can either be good for sleep, but it could also be bad in some other ways. So it really depends. But in terms of the social factors, the same, it can go either way.
Okay, we have another question in the chat. It says, social determinants of health solutions seem like they will take time to achieve. What can we do to help people now?
Yeah, so change definitely takes time. But I would argue there's steps of things that we can do right now to, address those, whether it's policies in the workplace to penalize things like workplace discrimination. That's a policy or upstream factor, but something that can bring change through working with leadership and human resources and so on within the organization. And then additionally, I would really encourage grassroots steps to tackle some of these environments or some of the negatives of structural racism. So, for example, we see that cleaning up vacant lots um, translates or is associated with decreasing crime, increasing social cohesion. It increases individuals' time outside. And that's not a lot of funds that it takes in order to clean or improve vacant lots, planting trees. These are simple things that we have data that shows that it improves the environment, and all of those factors can improve sleep. It can improve physical activity. We see other grassroots things like farmers markets, placed in communities which are addressing things like insecure food environments. And so while, yes, I agree, things at a policy level, largely that's dictating budgets for education, yes, it'll take time, but it's through the work that we're constantly doing daily to bring recognition to these factors and hold our politicians responsible for moving this agenda forward with addressing social determinants. So some work we're doing now is encouraging clinicians to collect data about social factors. A talk that I give, really highlights the zip code as important, if not more than our genetic code. So we're quick to collect some of that data, but we're not using the data around zip code as a risk factor or even to target a specific population. So we have enough data that we can take some of that information to be able to design interventions and strategies that target populations most at risk to bring about this change.
And another question, I want to acknowledge that it is Mental Health Awareness Month. You talked a lot about dealing with stress and how that affects sleep and then in turn affects our risk of disease. So what are some things you think we can do to, I guess, protect our mental health, I guess at an individual level, but also at a neighborhood level that would help us for health overall?
Yeah, great question. So my group actually just completed a intervention where we had participants engage on an app within a few hours of bedtime, not right at bedtime, to reduce that light exposure. But essentially, they did a mindfulness meditation. So we found by having individuals engage in breathing exercises before bed, not watching television, not scrolling social media, but by being intentional and going through mindfulness to reduce stress and anxiety, um, it resulted in people falling asleep quicker, staying asleep longer, and having feeling more rested during the day. So this is something simple that we can do. It's just about reducing our amount of stimuli at night that can be triggering and really bring ourselves into this calm space before bed. So that's an individual level thing that can be done. In terms of reducing stress on a neighborhood level, so going through some of those strategies that I, previously discussed, I want to point back to this really nice framework that was created in talking about these different emerging factors. And so some things that can be done is um, investment in neighborhoods, for example. We see that more built environments, although there's a trade-off for sleep, more built environments relate to better mental health. So again, the having neighborhoods that are more aesthetically pleasing, planting trees, having flowers and so on in the environments, we see that that tends to also help. And so when you have that, that can also affect the individual level behaviors. People are more likely to spend more time outside. And so if we can change our environment, that can reduce some of the stress levels. And then also just watching our triggers. And so in this age where we see a lot of videos that are recording events that definitely help in prosecution, they can also be triggering to our mental health. So we have to be careful about what we're viewing, the timing of those being viewed and so on to protect that mental health space.
Well, thank you, Dr. Johnson, for giving us an excellent presentation and a consideration about thinking about how sleep affects health. Before we end, I'd like everyone to complete our brief satisfaction poll. It helps us to plan our future events. And also, if you have not completed the learning community survey, I would like to invite you to fill that out. So we're going to drop the link in the chat. For that survey, there will be a $25 Amazon gift card raffle for those who complete the survey. And I do also want to highlight our upcoming events. So I didn't pay Dr. Johnson to say mindfulness, but she hit it right on the head. Our next learning event, it will be next Wednesday, where we have a mindfulness 101 workshop. On May 31st, we're going to have our community orientation. And then in the next part of this series, for our next social determinants of health workshop, we will have Dr. Bill Lopez from the University of Michigan, who will talk about immigration policy and health. So we hope to see you at all of these events. In order to stay tuned, make sure that you are logging on to our community website at vaxequityurban.org. And everybody enjoy the rest of your day.